So we're delighted to have Dr. Liz Harry with us today. I'm not going to read you her lengthy, impressive bio. Let's just say that she comes to us from many other interesting places and saved the best for last to come to Michigan and really make an impact on the burnout, the stress, the work efficiency, the well-being, and the wellness of our, not just patients, providers, learners. And so I'm not going to waste a lot of time talking about her because I'd rather let her talk herself about the work she's doing. But for those of you who are new to the seminar, which is not really a seminar, Liz is going to talk a little bit about a problem that she's challenged by in her work. And then the goal, as you all know, is to come up with lots of ideas that she might not have thought about, vet each other's ideas, try and take something that might not work and find out a way to make it better so it does work. No idea is crazy. The crazier the idea, the more likely you are to get, presents from me and an A+++ for the class. And let's see what we can learn about burnout today. So thanks, Liz, for being here.
Absolutely, thanks for having me. Well, I'm excited to be here with you all. And so we're going to talk about what factors and processes contribute to cognitive overload in healthcare and why that's important. But we're going to just pause. So I know you guys are all very smart students or guests for the lecture, and you may understand all sorts of things about cognitive load and cognitive overload, but I want to make sure we're on the same page about what it means. So when I say the phrase cognitive load, think back to the last 2 weeks of your life. What do you think about? What are some things that you think about? Yeah. Career fair. Tell me more. What does that mean? Preparing for it or what?
Not really preparing for like last year I maybe feel stressed out about like talking to people, interact, but this year I know that I still need to apply online, so I'm just more chill now. And
Okay.
I'm just there to talk and add their linking and that's it.
And that it can be all the pressure, right, too, of like all of the options and all of the things that are available and all the people you could talk to. Yeah, there's probably a lot of cognitive load about just like thinking about your future, right? Yeah, it's a really, really good example. What are some other sources of cognitive load for you guys in your life?
You can go. I think when I think about cognitive load, I feel it most when I have like multiple different tasks that I need to be focusing on and all of them are important.
Yes.
And so I need to like split my attention in a way that's efficient and getting things done.
Yes, and we'll talk about like, should we split our attention? And is that the best way to get it done? Yeah.
Similar to that, just not having like enough bandwidth to manage everything that I have going on.
Yeah, I love that. So there's always that classic, raise your, and then I want you to raise your hands back up, but raise your hands if you've seen that classic thing where there's like big jar and they're like, if you put the big rocks in first and then the pebbles and then the sand, you can fit all the things in your life. But the problem is, what if there's too many big rocks for the jar and nobody's done that thing yet, right? And that's sort of where we're going with this, is there's too many big rocks for the jar. And so absolutely, what are some other examples? Yeah.
Like when midterms and finals come around, that you really have to like study for all of your classes and it's like a lot at a time and having to remember everything you've learned. And
Yeah, and you have to synthesize everything from the whole semester, and you might have, totally different subjects that you're trying to remember things. Or they're similar, and then you're like, was that for that class or that class? And that might even make it more complicated. Yeah.
Planning a wedding.
Oh, so much cognitive load. Yeah, right. and then what goes wrong and all the things. Yes. Yeah, absolutely.
I was just talking about like moving. So this is my first year here. So I moved from Virginia to here.
Okay.
And then I have to take care of my license and my car registration.
Yes.
And then schoolwork here.
Yes.
And then rent a house.
Yes, I just moved here a year ago. Totally hear you. In fact, I have a little bit of PTSD when I come around here, I realized, because I had to come for my parking permit. And I was trying to figure out, where do you park when you're going inside for the parking permit? Because no matter what you do, it's a catch-22. There's no like good place to park to go get the parking permit. I didn't get a ticket, but so much cognitive load, right? Just getting your license. I have kids, so it's like, where do they go to school? All the things, right? Yes, lots of that. Yeah.
So I had to say I'm also planning for a wedding.
Okay, all right, I love it, and I love the active participation in planning. There's so much to do. Yeah.
I'm not planning a wedding, but I'm in the red zone when I'm watching like 4 games at once.
Right, and your attention is split, and you're having to go out. So Yeah, so we'll talk about that. We'll talk about that, yeah.
So I'm sitting here finishing off some urgent patient labs.
Yes.
Trying to sit in this seminar, does that count?
Yes, 100% it counts, right? And so in the back of my mind is that I haven't looked at my in-basket yet today, right? And I'm like, what's gonna be there? And that'll be my homework after the kids go to bed, yes. So the concept behind cognitive load is that and some of you know this, and this is gonna be old news, and that's fine, we're all just getting on the same page. The concept is you have a finite amount of attention. You have a limited amount of attention. It doesn't matter who you are, it doesn't matter how much you train yourself, you have a finite amount of attention. And you use up that attention by the things that you are all talking about, right? And 3 things impact how much of that attention you're using at any given time. So the first is how complicated is the thing that you're doing? How complex is it? That's the intrinsic load. So studying for finals, trying to plan a whole new life, plan a wedding, like all these things, these are really complex things, right? If I am trying to answer really complex medical questions from my patients, can I answer a call about a different patient without increasing my risk of error? No, I might increase my risk of error. Now, if I'm playing basketball or Play-Doh with my kids, can I answer that call without increasing the risk? Probably. Should I? Different lecture, but could I? Probably, right? So thinking about how complex the task is. What we do is complicated. There's nothing we can do to change that, so we're gonna put that to the side for a second. The second thing that impacts it is how much expertise do you have at dealing with the information? So if you are new to what you are doing, you are spending some of the time learning, dealing with the data that is in front of you, and you're spending some of the time learning mental models about the data that's in front of you. So if I have a medical student who's never seen a patient with a urinary tract infection before, all the data associated with that urinary tract infection, they treat as separate data points in their brain. But for me, I chunk those all together, I put it into my mental model called urinary tract infection, and I treat it as one chunked data piece. So I can process more data because I have expertise with it. That's called the germane cognitive load, and it's the amount of cognitive load you're using to build mental models. It's important, we want to be lifelong learners, but you can't do anything about that in the short term. So we're going to put that to the side. So then there's the really bad kind of cognitive load, which is extraneous cognitive load. And it's everything that is not intrinsic to the task itself, but it's how we present the information to you. So what are the drivers of extraneous cognitive load? There are 3. So you mentioned 1, split attention. So when our attention is split, also the games, I don't know, I missed what you're, the red zone, okay, I don't even know what that is, but okay. So when your attention is split across screens or across tasks, that is increasing our extraneous cognitive load. Every time we move from one task to the other and back again, we lose 90 seconds of data. It's called an attentional blink, and it's a very inefficient way to work. This is pertinent because we're gonna talk about how we round on patients. We're gonna talk about the environment that we round in, yeah.
What does 90 seconds of data mean?
It means that, so if let's say you're switching between like writing an email or responding to an email and you're like in a lecture. If you go to the email and then you come back to the lecture, you will have missed about 90 seconds of like what I was saying in the lecture as you reframe and reorient and be like, what is she talking about, right?
So on top of the information that you lost.
Focusing on the other thing.
An additional.
An additional 90 seconds. And that's important. So it's called an attentional blink, and it's really important because it's outside of your awareness. So you don't actually even know that you missed the data. And so if it's like this lecture, that you know, and an email, maybe that's okay. But if we're talking about a patient vital sign or something that a medical student or a resident is reporting that may be really critical to the care, maybe it's less okay. And so we want to think about where is the attention of the people who are listening to the things, right? So we talked about split attention. The second thing that drives extraneous cognitive load is redundancy. So this is getting information multiple different ways. We were talking on the way over about the in-basket. The in-basket is like the epitome of redundancy. I discharged someone the other day and I was notified 7 different times. Sorry, I had a patient discharged from the hospital. I'm their primary care doctor. I was notified 7 different times that they were discharged. 4 were faxes. A paper folder that I had to sign, and they were identical faxes. 3 were in the electronic health record in separate folders, and when I cleared one, saying like, I see you, I understand this person was discharged, it didn't clear the other 2. And the worst part is there might be like 7 people behind those processes.
Can you talk about the trade-off? I completely get like it's a volume issue, right?
Yeah.
So if volume's the problem and you give me the same thing 7 times, you've just increased my volume.
Yeah.
what is the trade-off? Like my instinct is, yes, but I'm so busy, I might have missed the first three. Like when does redundancy or reminder, how many of my students have sent me more than one email? And that's actually a good thing, right? Because
it
it's drawing awareness. So what's the trade-off?
It's this like feed forward cycle, right? Because why do they have to do that? It's because you have so many emails, right, that it's hard for you to pull that signal from noise. So they're like, I'm signal, right? So they're putting more chances that they get to be signal out of all of your noise. But if you looked at all the noise and you could cut it in half, that might not have to happen, right? And so, but there is this sort of perception in healthcare that redundancy equals safety. So I don't know if anyone has seen like a quality and safety talk where there's Swiss cheese models, like Swiss cheese slices, right? So that's the theory of active and latent failures where it says that multiple things can line up and lead to an error. What it doesn't say is let's then put 6 layers of redundancy under every process, which is kind of how we've interpreted it. Now, if you're going to take one of my limbs, please double check before you do it. If you are going to give me a transfusion, please double check before you do it. There are things that we should double check. But if someone has been discharged, I don't need to know 7 times. And the problem with it is we might have 10 processes and 3 failed. I don't know. But I do know that we don't have one highly reliable process. We have at least 7 moderately reliable and highly duplicative processes. So we have redundancy, we have split attention, and then lack of standardization. So this is gonna come up in the rounding example. This is when I go into one clinic room and the pap smear stuff is here and the throat swab stuff is here, and then I go into another clinic room and they're like flipped, I have to remember that difference. Or if we're rounding on an inpatient ward and the interdisciplinary rounds go this way and the nurses hang out over here, and if I wanna find them, I go there, but I go to another unit and it's all different, I have to remember that difference. So extraneous cognitive load is modifiable. It is where we want to pay attention in thinking about how to reduce cognitive load in healthcare. So the 3 drivers of extraneous cognitive load are redundancy, I'm being intentionally redundant, redundancy, split attention, interruptions fall into this category. Every time you're interrupted, it takes you 90 seconds to refocus. Redundancy, split attention, and lack of standardization. So for standardization, I want you to think of like, why did Steve Jobs wear the same outfit every day? Right? Why do you put your keys in the same spot every day? The more that you make a habit, it comes out of long-term working memory, which is not limited. We've been talking about short-term working memory, which is limited. So that is the background on sort of cognitive load and cognitive overload. Based on what you all know, what sort of things do you think might be contributing to cognitive overload for healthcare providers? Yeah.
It's something that we haven't talked about, which I'm curious where you would put this. But say I have like 3 outstanding prior auths that are like looming over my head as I'm trying to do whatever my day-to-day is, and I'm still thinking about this needs to get sorted out. It's really annoying. It's really frustrating.
Yeah.
What kind of cognitive load is that? And I can't imagine that's fun to deal with on a daily basis.
Yeah, so I would say that falls into that extraneous cognitive load, right? Because it's splitting your attention over here. If you had a reliable system where you knew I could put these 3 prior auths into this system and they will get done and I don't have to think about them again, then you don't have to keep splitting your attention. It's when we don't have systems we trust that then our brain continues to scan the environment for like, was this thing done? Right? And I think that's where it gets really tricky. Now, the second question is there a reliable system to do the prior auths, or am I as the physician doing them? Which I think is a really good question. So that's a great example. The other piece of your example that makes it great is that a physician task that needs to be done, right? And that drives cognitive load too, because there's this belief like everything is safer if the physician does it. That's not actually true, because we're overloading the physicians. We're making it harder for them to pay attention to the data they need to pay attention to. What are some other things that might contribute to cognitive overload for healthcare providers? Yeah.
Fatigue, stress, and burnout might actually reduce your capacity.
100%. So while we can't make our working memory bigger, if we are fatigued, stressed, or burnt out, our capacity shrinks. And if we do continuous partial attention all day, where we sort of split attention and focus back and forth and we don't ever give ourselves cognitive breaks, then we deplete our working memory. So you know you've done this when you get home and someone you love says, "What would you like to eat?" And you're like, "I don't care. Just food," right? I can't possibly make another decision. And this is because you've depleted that working memory resource all day. Turns out you can take a cognitive break and replete that resource, what would count as how about this, what wouldn't count as a cognitive break? Can you give me an example of like not a good cognitive break? Yeah,
Hockey flashcards.
I don't even know what those are, but yes, what is that?
Talked to a med student in the last 10 years.
What is that?
Auntie, it's like flashcards for like board exams.
Okay,
Like
okay.
kids just doing it all the time.
That is not a good, that is not a good cognitive break. What else? Charting, yeah, so like doing more cognitive tasks.
Watching TikTok?
Yeah, anything you're scrolling, right, is not a good cognitive break because it literally, your attention is what is being bought and sold in the moment that you're giving your attention to that, yeah. So what would be a good cognitive break?
A nap.
A nap would be great. Let's say you only have 3 minutes, so 3 to 5 minutes.
Jumping jacks?
Yeah, like changing your physical state, just a walk, yeah.
Meditation.
So meditation is interesting, people bring this up, so no. And the answer, and the reason is, right, if say you're running a track meet and you do an event, in between events you wanna stay warm, but are you gonna go sprint a 400 in between your 400s? You're not, right? Because you don't wanna train for your event during the event. Now, meditation trains focused attention, so it's really important to do, but you don't want to train in the middle of your focused attention things. You wanna take a true cognitive break, you can let your mind wander. The opposite is sort of mind wandering, right? And then other times you wanna train using meditation. So great tool, but wrong time. Yeah.
Get a snack.
Getting a snack, yeah, exactly. So like changing your physiology, this gets back to the physiology point, yeah, changing the physiology, getting a snack, talking to a friend, go on a walk, listen to music, any of those things work really well. Okay, so what are some other things that might contribute to cognitive overload? So high patient volume. So I want you guys to think about what happened. Our baby boomers got older, right? So we have more patients that are more complex and sicker than they've ever been. And they're on more medications than we ever had before. And we have more diagnoses than we ever had before. And we're able to keep people alive longer than we ever were before. So we have we have more patients, we have more complex patients, they're taking more medications. So whenever you hear from someone like, well, in my day, I was able to do that, was so easy. And it's like, well, yeah, it was a lot simpler then, right? It's a really different situation now. The interruptions and distractions. So if you're on the inpatient side and you're seeing patients, there are alarms constantly going off, right? So I actually had a colleague from NASA who came and shadowed me inpatient one time, and I was hearing from a resident about a patient that I was worried had cancer. We had just diagnosed another patient, or were concerned another patient had tuberculosis. I was looking behind me to make sure they weren't put in the same room as I was like worried about these two things. And apparently an alarm went off at the same time. My colleague from NASA thought for sure I was distracted by that alarm and that's what I was turning for. I didn't even hear it. I didn't hear it at all. I was just looking to see where these two patients were. So I think it's really important, and there's tons of literature on alert fatigue, right? And understanding that there's all these alerts coming at us. Time pressures, so really tight schedules, especially in the emergency departments. Our EHR systems, we were talking about that earlier, so it really helps in a lot of ways, but it has created a lot of redundancy. Something that people do is copy forward notes, which is adding to the noise, right, of your email. That is the same version of adding to a bunch of noise. So then you have to go through this like really long note to find the one sentence that they actually wrote that is new and meaningful for the day. So tons of noise, little bit of signal. So we talked about information overload. You guys hit all of them: shift work and fatigue, coordination challenges. So we have more groups to coordinate with. So our nursing colleagues, we want to understand, what's your assessment? What do you think? What concerns do you have? Our physical therapy colleagues. I'll tell you a short story. We had a patient who was inpatient. Their team said on Friday they are ready to go. They just need a line put in so they can get these IV antibiotics at home. And they couldn't get the line until after the holiday weekend. But the physical therapist said, they're fine, they're ready to go, it's fine. So the whole 3-day weekend happens. First thing Tuesday morning, they send the patient to go get this line so they can go home. A new physical therapist comes in and says, no, this patient has to go to a skilled nursing facility, because it was a different physical therapist than was on the team before. Then they have to get the whole social work team in, say, okay, let's try to get them to this rehab facility. The rehab facility denies them. And then at 5 p.m., we are back at sending the patient home, which really we were ready to do on Friday. Right, but they couldn't get sent home until Tuesday night because of that like lack of coordination of care. And then the emotional stress. So you guys hit on that really well. So before I move on, thoughts Yeah.
What about de-delegation? One of the phenomena that we see in EMRs is risk-averse administrators insisting that only the physician can address this or that document. You can't have staff do it, you can't do it as a team.
Yes.
Everything has to be kicked up to the highest level.
Yes.
And so the institution of an EMR can actually increase the physician's
100%.
workload.
Yeah, and as we were talking about earlier, there's this sort of misbelief that everything is safer if the physician does it, and it's not, because you're cognitively overloaded and administrative tasks aren't safer from someone who's not trained to do them. If you think pre-EHR, you wrote an order on a piece of paper and you handed it to someone who transcribed it and called and did all those things, you are now that person. You were entering orders. That was not a task that you did before. All sorts.
And following them up and
Yeah.
and tracing it down when they don't go through and so forth, yeah.
Yeah, 100%. I think you're right.
Question, how much do you know about like frozen sections for like oncology working with pathology live in surgical theater?
A little bit. My husband's a pathologist, so just what I hear, but
The question is, do you think a task like that they're both trained in, they both know, but it isn't routine, it's like a new thing that'll pop up and then everybody's gotta go do that
Yeah.
because it's real time?
Yeah.
Is that something that would increase cognitive load because it's a coordination challenge, or would it actually decrease cognitive load because they're doing a new thing?
Yeah.
And they're fully switching.
So there's like so much richness in your question, right? Because so part of it is staffing. How are they staffed, right? So a lot of times if we staff to like we barely staff to what we can do, then you're pulling away from something else, and then now you've got all the stuff that you have to finish later, or you were mid-thought or whatever. However, I will say that I do think that the surgical space has done a very good job creating a sterile cockpit, if you will. And so in aviation, they talk about a sterile cockpit, this idea that there are no distractions that come into the cockpit. Surgical spaces are a lot more like that, right? Where there's a sterile cockpit and there aren't interruptions, people hand their pagers away. If there is a very urgent interruption, someone will ask. People often pause what they're doing to respond to that, right? And then go back to it. I think surgery is a field we can learn a lot from in terms of creating a distraction-free environment. So in that way, I think that there's then focused attention, or the opportunity for focused attention, in a way that you often don't have in other spaces. So I think it's kind of mixed, and it depends on how the system is set up.
Thank you.
Okay, other thoughts? Yeah.
How much do you think like different things that hospital admin ask of physicians adds to the cognitive load? So for example, like different surveys or different, projects that they have to be a part of. Like it adds to their kind of work
Yes.
flow, but it's
Yeah.
not really relevant to like the clinical.
100%. So oftentimes when I talk to people, particularly, our frontline folks that are listening to this talk, there can be a sense of like there's someone up there that is aware of this experience I'm having and is like endorsing all of this load coming onto me, and they're okay with that. And the truth is actually scarier in that there's no one person that has any idea what any individual's cognitive load is, because we're in such a matrix, complex environment where there's all of these committees and all these different groups that are putting things together like surveys or roll out this quality improvement project or whatever, and they all confluence on this one person that's having this unique experience that no one else is really aware of. And so, yes, that happens, but not through intent. It's through complexity, and it's through lack of oversight and awareness of this level of complexity. So I'll give you a really short example. We looked at the number of alerts in the emergency department and found out that we had alerts that were getting clicked through that people weren't acting on. We were effectively paying 6 full-time physicians and 3 full-time nurses to do nothing but click through alerts that they weren't acting on. And 40% of the time they abandoned what they were doing before. Like they never went back to it because of that 90-second attention loss thing. So yes, it's happening, but it's not because anybody's like Machiavellian. It's because the complexity. It's like a meta property of the complexity.
Part of what I find so important about what you said is this notion of we don't know what other people are experiencing in terms of cognitive load on top of everything else that we don't know what people are experiencing. And one of the things that I had learned about and have actually sort of used a little bit is that in certain health systems, the nurse who's going around delivering medication will wear like a safety vest or something. And that's basically like wearing a sign that says, I'm counting, don't interrupt me mid-count.
Yeah.
And I've actually started, so just life hack for any of you, a bunch of people about to get married, my husband works from home. He likes to work in the dining room. There are days that I come through to get a glass of water and to say, how's your day going? Did you see the ball game? Whatever, is like a nice water cooler break for somebody who's isolated working from home. There are other times that he's working. And the joke is now he puts on his Red Sox cap.
Yeah.
If he's got his Red Sox cap on, it means I'm in work mode, pretend I'm not here. Yankees fan? I don't wanna know about it. But that idea of being able to say to the people around you, this is a time that is not good to disrupt. And I think between email and pagers and Slack and the number of ways you can communicate with people, unfortunately, I think we've lost that ability to say, it's okay for me to wall off a chunk of time with the expectation that I'm giving a lecture.
Yeah.
I'm not gonna hear messages for the next 2 hours.
Right.
And that should be normalized.
Yeah, and so many important things there. So I have 3 kids and I do a job where like I talk a lot and receive a lot of information all day and then the kids like come at me with all this stuff when I get home. And so I have thought about getting a bright yellow hat that is like, give me 10 minutes, please, like to just have quiet, right, to reset my brain. So I love that. And I think it is important to sort of briefly talk about how we can pay attention so that we think about this tension. And what you're naming is a tension between availability and attention. So if I am infinitely available to you, yes, call me anytime. You can call me anytime, I'll pick up. Page me anytime, text me, Teams me, Snapchat, whatever the things are, like all the things I will be available. I can't pay attention to anything. If I am paying attention to something and I'm giving it my full attention, I cannot be available to you. I have to turn off all the ways that you can get in touch with me. And I think it's important for us to acknowledge this tension between availability and attention because we want our care teams thinking about us in a focused attention way. And they have to be available, right? If we're inpatient and someone is sick and someone gets sick fast, which happens often, someone's got to come. So how do we set up a system where someone's available, but someone also gets to think? Because you can't be both. And we're sort of acting like you can be both. We're not acknowledging the science that you can't be both. So before we move on real quick, I just wanna, and again, you all may know this, I don't, but I wanna make sure we're all on the same page. So there's a couple ways that we can attend. There's focused attention, and this is the ability to focus on something for a long period of time. So like I remember when I went to study for the MCATs, I had a bunch of snacks, I sat near the bathroom. I don't think I left the library for 13 hours. I wouldn't be able to do that today. I don't have the attention span to do it anymore. And I think as a society, we are losing some of that attention span, the ability to just sit and focus. My son has like 90-minute classes and he's like, these are way too long, you know, and maybe they are now, I don't know. This is 90 minutes, I think, so maybe not. But so focused attention, right? Then there is selective attention, and this is the ability to choose where you're going to place your attention. So in this room, think about all the things you could be attending to. So you could be looking at the board. You could be looking at your devices. You could be thinking about something that's going on in your brain. You could be thinking about your phone. You could be thinking about something physiologically. Maybe you're cold, maybe you're hot, maybe you're hungry, maybe you're frustrated. You could be thinking about a conversation earlier or later. There's a million things to attend to, and you are choosing, intentionally or not, where to place your attention. So that is selective attention. Then there is alternating attention, which is when you then thought between 2 things or 2 or 3 things that you're choosing to put your attention on. Right? And then there's the worst kind, which is continuous partial attention, which is where you are not fully focused on anything and you are giving a couple things part of your attention, but you're never really fully attending you're doing this back and forth with parts of your brain. And we do a lot of this, and that's the thing that depletes the most of your working memory. So I'm sharing this because when we think about the environment in which we deliver care, what kind of attention do you want your care team giving to your medical conditions? Because I would really like some focused attention. But that's not the environment that we're setting up. Okay. Questions about factors contributing to cognitive overload? Okay. So our daily rounding. So rounding came from like the 17th century. And interestingly, apparently the term came from Johns Hopkins, like early 18th century, where they had these hexagonal like rooms or wards where they would sort of go around and look at all the patients. Now what it means is we have teams that have 8 patients on 8 floors with 8 different nurses and 8 different physical therapists, and they spend their time walking all over the hospital. So they are not rounding, but that's where the term came from. The purpose of rounds is to bring information that is available about the patient to the person who's ultimately making the decision, in this case, the attending. The other purpose of rounds is to educate the person who's bringing the information. So I am a learner, and part of the way I'm gonna learn how to make these decisions is I'm gonna gather all the information and I'm gonna bring it to the attending, and I'm gonna tell them as best I can what I think is signal, what is noise, and what we should do. So that's sort of the purpose of it. The way that it came to be was there used to be information all over the place, right? So there used to be vitals hanging on the door outside the patient's room. You'd have to go look at the chart and like pull it down and see what the highest temperature was overnight and write that down and write down all the vitals. Then you'd go to a system where you got the labs, and that could be that you actually went to printouts at the lab, depending on when you trained, or that there was a system in the EHR where you would get the labs. Oftentimes you would then go to get consultant's notes, which would be in the paper chart that was stacked like by the nurse's station, and you would go get the paper chart and make sure you looked at the nurse's or the consultant's notes. The nurse's notes would be in a separate place. You would go then and see the patient, see how they are doing, how's their physical exam, what do they look like, do they have any complaints? And you would synthesize all that information into a consolidated presentation where the attending comes and you say, here's all the data, and you do it in a very systematic format. So you would say subjectively, the patient said this is how they feel. Objectively, they look like this, these are their labs, this is what's going on. My assessment is they're getting better, worse, or staying the same, and my plan is I wanna do this diagnostically and this therapeutically. And you would do that for each problem, or you would do it by systems. So this is how we sort of structured rounds, and we structured rounds like this a long time ago. Part of the purpose that this was serving was consolidating all of that information. What's happened is all of that information is now in the electronic health record, except for what the patient has to say and how the patient looks. Everything else is in the electronic health record. People are so overloaded with how many patients they have that often when they come in pre-round, they're not actually seeing the patient. Sometimes they do, and hopefully they do, but they don't always. So what rounds now looks like is I have a tablet as an attending here, and it has all those things I just told you, the vitals, the labs, all the consultant notes. And then I have a learner in front of me who is reading to me the same things that I have in front of me, because that's what we decided to do in the 17th century. And we haven't changed it at all. And so then in theory, I'm supposed to teach them something. I'm supposed to teach them about physical exam or about medical decision making or something like that. And we would go to the bedside and we would talk to the patient. But now most rounds are actually not even held at the bedside, they're held in the hall. So we go out and we sit in the hall and we talk about the patient, and sometimes they can hear us and sometimes they can't. And then we go in and we tell them very quickly what we're gonna do when we do a cursory physical exam. There was a study recently looking at how often physical exam findings are even taught during rounds, and it's very infrequently. So we're not teaching physical exam, and we're really barely like touching the patient. There's a great article called The Eye Patient that's sort of like, you know, the iPhone and the eye everything, right? That we are like, we have a digital patient and a digital story, and we're not actually going to talk to the patient. And part of this is because we have more patients. Part of this is because they're more complex. Part of this is because there's more data. And part of this is because we're all over the hospital, right? We're running from room to room to room. So that is the purpose of daily rounds. So it is supposed to achieve a couple things: educate the learner, inform the attending, inform the patient, and in an ideal state, inform the rest of the interdisciplinary care team of what are we doing today, and do you agree, or are we gonna have a team member come in and say, this patient has to go to rehab, they can't go home. And then the whole discharge plan that we've had for 5 days goes a different direction for 7 hours until it doesn't, right? So those are the objectives of rounds. Questions about why we round or how we round or what it looks like. Yeah.
It's kind of surprising to me that the interaction with the patient isn't given more priority in the description.
I agree.
It's like concerning.
Yeah, I agree. And I hope I'm not misrepresenting the interaction with the patient. But based on what our patients tell us, so they've actually studied this and the amount of time that teams spend with each patient on rounds. They have studied whether if you sit down, if the patients perceive that it is longer, but the average amount of times that a team spends with a medical patient on rounds is 8 minutes. And the patient perceives that it's 12 minutes if you sit down. So they perceive it's longer if you sit down and take the time to talk to them. But you're right, that this part about talking to the patient, which ideally should be the center, there have been some movements in pilots to move everything back to the bedside and have interdisciplinary bedside rounding where the whole team comes to the bedside and rounds. And I have seen organizations that have gotten that off the ground, and I have been part of getting it off the ground. It is hard, it is doable, but it is logistically very hard because everybody's got their drivers. Physical therapy has their list of however many patients that they're supposed to see. So yes, I agree with your concern.
Is there like a difficulty in getting the interdisciplinary team at one place at one time? Is that like the problem? Like some might have certain patients and others have different patients?
Yes, so the way most places are set up, and we'll focus here at University of Michigan, the way it is set up here is that as a physician team, there isn't a consistent group of nurses, for example, that are also seeing the same patients. So a nurse may have 4 patients and she or he may have 4 different teams that are caring for those 4 patients. A physician may have 8 to 12 patients and they may have 8 to 12 nurses caring for those patients. A physical therapist may have like 30 patients that they need to see that cover multiple teams. So yes, yeah.
You mentioned kind of in a way that made it seem like we do this because it's the way we've always done it, but you mentioned that rounding has been pretty much the same since the 17th century. Like, have there been discussions or things about like, do we still need to do rounding with new technology? Do we like, is there a different way we can do it better? Like the bedside thing, like how much thoughts do you have?
Yeah, I think it's really great. So there's a guy named Jason Stein, he came out of Emory. He came up with this structured interdisciplinary bedside rounding and got a lot of traction around that, I would say 2014, 2015. And there are some organizations that picked it up and were able to go with that. In order to do that, you have to move to geographic cohorting, meaning that the patients that come in, like this hallway, all the patients that are there are belonging to the same specialty, right? You couldn't have like a cardiology patient and a pulmonology patient. They'd all have to be, say, general medicine. And then a team sort of owns those beds. So anyone who comes into those beds are your patients. This changes for our residents how they admit. So our residents right now have a call schedule. If you own beds, you're admitting every day because when someone leaves, then you have a new patient. So that's a huge like buy-in thing that changes things, and it's sort of a prerequisite for being able to get this cohorting with our nursing colleagues so that then we share patients together, we get to know each other. Then we get to round together and have more of this communication. Getting physical therapy is really hard because it's not how they're reimbursed. And so it's like asking them to take an hour, 2 hour out of their day that just slows them down and doesn't help them sort of get reimbursed. I'll tell you also, I had a colleague at Brigham and Women's in Boston, and he had this method, which I loved, which was asking the trainees, for a new patient, you get to give me 7 data points. That's it. And for an old patient, 5. And if you really, really, really make a good argument, you could give an extra one. And a data point could be anything, a physical exam point, something they told you overnight, something a consultant said, but you need to find the signal and do not give me any noise. And his rounds went very fast and they had time to be in with the patient and time to do that teaching because they weren't talking about all of this waste. But as far as I know, he didn't write it up and I haven't seen it go anywhere. Yeah.
You happen to know why older patients got less data points?
Oh, meaning like they're not a brand new patient to the service, so we know them.
Sorry.
So not age, yes, yeah, so meaning if you got admitted overnight, then I probably need to learn more about you, and so you get to tell me more patients or more data points, but if you've been here, then I don't. And this was arbitrary, I mean, there's nothing evidence-based about what he chose, it doesn't make it necessarily the right way to do it, it was just a way. Yeah.
One of the things we've noticed in studying teams in outpatient primary care is a sort of an informal communication effect. Teams that are co-located and interacting during the day and so forth engage in a great deal of informal, unstructured communication that seems to pass a lot of crucial information. Groups that are responsible for caring for patients, but they're here, they're there, they have a very structured form of information exchange, actually end up with much less rich information exchange. It seems that, just informally observing this, it seems that the groups that have a lot of the informal information exchange seem to tax their working memory less.
Yes.
Does that make sense?
I think it makes sense on so many fronts, and one of which is the relationships that are built too, right? And so you learn each other, you learn when somebody's stressed, you learn when they're like, ooh, there's something I'm really worried about, we need to respond to this. So I do primary care now, and I went from a place where we were co-located with our team to a place where we are not co-located with our team, and I have 100% seen that difference. The other example here would be the intensive care unit, right? So most intensive care units are closed, and the nurses are at the bedside, and usually the physicians are like sitting right there all day available. And there's relationships that are built and people know each other, and there isn't this depersonalization that happens. And we all know what happens when you get a little bit depersonalized and you're behind the mask of a text message or a little bit of anonymity, then our courtesy also goes down, right? And our sort of support of one another goes down. So yeah, I think that makes a lot of sense. Other questions or thoughts about how we round?
Is it, so like that informal communication is valuable. How often, is it like a learner and an attending are all going to like all the same patients together? Or is it like a learner's going to like 5 different attending and each attending has 5 different learners for each of their 5 patients?
Yeah, so all the variations exist. So I have seen programs where, for example, attendings have to staff patients with different residents, residents have to staff patients with different attendings, like across services and things like that. What I have seen here is like you'll have 2 interns on a team and then the chief resident. And what's typical, because we want to maximize efficiency because we're very overloaded, is that one intern and the resident with their attending will go round on that intern's patients. Now that means there may be a nurse that actually has a patient with each of the interns, but we're asking that nurse to come twice to the bedside because we're doing all these patients, then we're doing all these patients for the other intern. It may mean there are 3 patients on the 8th floor, but we're going on and off the 8th floor a bunch of times because we're first seeing this one intern's patients and then seeing the others. So it's like, what do we prioritize? And in that circumstance, we've prioritized the ability for one of the interns to go do work or stay back and do work. But they're also then not learning from any of the other patients. They're not learning any of the physical exam findings or any of that.
Makes sense.
Yeah.
It's difficult.
Yeah,
I just had a comment I wanted to make about it. So I was doing a presentation last year, the one we did last year on Gator Rounds.
Right.
So it's kind of like about the dynamic shift between an attending and the residents and the nurses, and going from more like a captain on the ship style to more of a coach, and how that relationship, they turned to Gator Rounds and they made some like connections with like different, each role had like a specific position on the team.
Yes.
And that alone helped like reduce a lot of medical errors.
Yeah.
And I can only assume like it probably reduced the cognitive load on people too, just when you have a better dynamic amongst your team.
I would imagine, and I love that for so many reasons. One piece is oftentimes whoever's presenting presents to the attending, but really the resident's supposed to be running the team. And so models I've seen are that the intern or medical student will actually present to the resident and the attending is standing off to the side really to be a coach. Other models I've seen is that the team actually presents to the patient and says, you're experiencing this and you told me this morning and here's what I'm thinking about that and we were talking about this, but I'm worried about this, and that the focus is on the patient and that everybody else there is really to support the presenter in talking to the patient and fill in any gaps if they can. So I think that piece is really important. The other piece I just want to highlight here is like, think about when we teach you how to do something. We teach you how to do something because it's a skill you're going to use in the future. We don't ever present ever after residency. Ever. I haven't presented in years. So like we spend so much time doing this task, practicing this skill that we will literally never do again. Now what I will do is give one-liners. I will call another physician and say, I have a patient here who is a 45-year-old woman, she has this past medical history and I'm worried about this, can you help me think through it? The ability to take all the signal and make a really cohesive one sentence that explains what's going on to someone is a really important skill. But that's not what we're practicing when we round at all. So not only is it disconnected and we're taking all this time, but we're practicing a skill that they will never, ever, ever use again outside of training.
I feel like that's just kind of a massive overarching problem in medical training.
Yeah.
Like, I'm not trained as a civil engineer. If somebody asks me about concrete, I can't tell them anything because I'm not qualified to speak on that. But every med student has to know all of everything that's on the board exams to get their license, and it's I don't know, it's just whatever we're talking about, it screams the same issues that I had in med school, which is why are we drinking from a fire hose when I wanna be, an oncologist, I wanna be a pathologist, I don't care
Right.
about cardiology, the minutia, like,
Yeah.
so.
And I think what you're highlighting is this same concept that what we have done is take the same structure and just try to shove more in it,
Yeah.
right? And as there's more and more data, we're just like shoving more in, but we haven't changed the fundamental structure, even though there's more data.
I wanna shift gears just a little bit and pull a couple of different things together. So I think for many, another source of lack of attention is lack of ownership or lack of interest, right? That if I'm one of the 6 people on the rounds and no one's really paying attention to me and I'm not contributing, that's where, I'm sort of wandering off. And when we think about interprofessionalism in medicine, one of the things I find interesting is I often hear that physicians shouldn't do X, Y, Z because they're too busy or because they have more important things they should be doing or because they're cognitively burdened. And I would argue that one of the main reasons they shouldn't be doing certain things is because they're not the best person to do it. That's not what they're trained to do. And I think that part of the argument for interprofessionalism, so this idea that as you're training in medicine, nursing, social work and so on, that you're training in a more mixed environment is that recognition of who has the expertise. And so if you're rounding really effectively, ideally, every person in the group is an expert on part of what's happening. And it may be that the intern is the one who has spent the most time examining the patient but this idea of I'm going to be engaged if I feel like I am contributing and have authority, and that idea of if I'm just here, of course I'm not paying attention.
Right.
Because there's no need for me to be here. And so that's part of what I'm hearing with this rounding is you're telling me a bunch of stuff that I don't need to know and therefore I might as well blank it out.
Yeah, 100%.
I wanted to understand what was the original purpose of the learners giving a lot of detailed information to the attending. Was it so that the attending can verify if their one-liner diagnosis is correct or their assessment is correct? Or was it simply so what was the purpose behind that?
It was that the data was everywhere and the attendings had gotten to the level of seniority that they weren't going to then be collecting all that data, right? It is literally like, could you go find all the data and tell it to me? Because, right, right. So the original purpose was consolidate the information because it's on the door and it's at the lab and it's in the binder over there and it's in all these different places that I as the attending am no longer gonna go around and gather. So I need you to gather it for me. That was the original purpose, is like literally gather the stuff, which is why everything was reported. Because otherwise I wouldn't see it. As the attending, I would never have the opportunity to see that thing. So you have to tell me everything. But now you don't, because I have it on my iPad, like right in front of me. Yeah.
Is there some benefit that comes from actually interacting with someone as you're decision making versus you just looking at what's on your iPad and deciding yourself? Like, is there something that comes from this exchange and discussion that you wouldn't otherwise get?
Yeah, tell me more. So you're thinking like when the medical student is reading all this stuff and everybody else is looking at the stuff, is there like an exchange that's happening?
And that informs the decision making.
Yeah.
So it's not just a single person and what they might miss or not miss, but because they're interacting, because we're all hearing information,
Yeah.
because there's a synthesis, that the decision making and the quality of it differs than it would have if I just did it myself, regardless of whether it's sitting here on my phone and
Yeah.
I'm looking at it.
I think there's a really good question there, right? So like, so one of the things that I watch for with learners is what do you determine as signal and is it what I would determine as signal? And implicit in what you're saying is like, they might catch something as signal that I would miss, right? And so it can act as this sort of form of redundancy that we talked about. And then the question is like, how much of that do you need, right? Like how much of the redundancy do you want to make sure that there's or could it be done in a way where there's just psychological safety to say, here's what I noticed as signal. And so if the medical student says, this is what I noticed as signal and doesn't read any of the noise, what they determine to be noise, of data noise. If I, as the attending, am like, you missed a really important piece of signal here, I'm gonna point that out. If they presented something that I wouldn't have thought of as signal, it's an opportunity for me to question myself and be like, do I have a cognitive bias here? Am I making an error? Which is really helpful. I think that can happen probably without the whole exchange, you know what I mean? Because they're just presenting the signal. But to your point, like what value is there in that? The other piece is, how do we teach learners to synthesize signal and understand what signal is and pull that out? And do they need to go through all of it together in front of the group in order for that cognitive process to happen? I think is kind of what I'm hearing you say too.
Right, cause I feel like, say for my students, they do better when they work with other people and they have to talk to each other, they have to exchange ideas.
Yeah.
Because nobody knows 100%.
Yeah, 100%. So
there's this something value that comes from the interaction and the exchange.
yeah.
And I think from a clinical perspective, I would think it'd be all the more important.
Yeah, no, I agree with you. The one thing I didn't mention is that a thing that tends to happen is that the medical student comes in rounds and gathers the information and then sits with the intern first and they talk about it all. And then the intern sits with the resident and they talk about it all. And then the team comes together with the attending with the plan that they formulated. So there is a lot of that happening also before even we go on rounds. So before rounds, there's been a bunch of huddling because the medical student isn't presenting sort of an vetted plan to the attending. So that plan's usually been vetted by both the intern and the resident by the time it's presented to the attending too, just to add complexity to the story.
Yeah.
And can't you just prioritize discussions that happen at the final stage, I guess, that are confusing to particular people or things like that? And then prioritize, I guess, like what's they're getting from the EHR, so they can summarize it in a more efficient way.
So tell me more what you mean about discussions at the final stage.
You say that they're discussing it with the intern and
Yeah.
then again and again. So I guess like maybe if there's like 8 different people, I guess at the final stage,
Yeah.
right? Maybe like only like 4 of them actually need to like speak up in order to like I guess get a fuller picture, a better understanding,
Yeah.
right?
Usually that's what happens. So if there's a medical student who has the patient, the medical student will be the person who speaks because it's their opportunity to show what they know for their grade. So it's how they sort of show, but everything they're saying has been informed by the intern and informed by the resident so that they're like as prepared as possible if they have a good intern and a good resident. If there's not a medical student, then an intern is doing that. And they are also sort of demonstrating what they know. And if they're not doing that, then a resident is doing that. I will say that the volume of information exchanged goes down as the levels go up. And sometimes you'll just have a fellow that will round with the attending on like a cardiovascular service. And then those rounds get even shorter and the amount of information exchange gets shorter as the trust level builds also. Yeah. Okay, so quickly, I think it's important for us to talk briefly about the consequences of cognitive overload to healthcare providers. So what do you guys think? So we've talked about ways in which we're sort of overloaded. What do you guys think are some of the consequences or risks of being overloaded? Yeah.
Making errors in diagnoses.
Yeah. What else?
I think burnout is probably the biggest issue.
Yeah, burnout is a particular issue in primary care because it contributes directly to the large and growing shortage of primary care physicians.
Compassion, fatigue, anxiety, depression.
Yes, all of it, yes.
Communication
Yeah.
with the patients.
Absolutely. I think you guys may have gotten all of the ones we put on here. Let's see. So increased risk of burnout, higher rates of medical error, decreased patient safety. So we do know the increased risk of errors. We talked about that. Impaired communication, diminished problem-solving ability. So we actually talked about like how do we do medical decision making and how do we focus and think? And if we have all this coming at us and we spend this huge time doing this huge cognitive task, what is our working memory reserve at the end of it? Lower job satisfaction, negative impact on team dynamics. You guys hit all of it.
It's more than just lower job satisfaction, it actually impairs workforce supply.
Yeah.
You lose bodies.
Yeah.
I'm here, I'm not rounding right now.
Yeah, 100%. Yeah, this is why I have a job. Yes, yes. Okay, so we talked about the information that was most important for residents to communicate during rounding. What do you guys think? What did you hear is most important to be communicated during that time? Yeah. Chief complaint, like, yeah, why is this person here? And why are they still here? And how are they today? Yes.
Physical exam findings.
Yeah, are they okay? Are they getting worse? Are they getting better? Is there something that I need to go look at right now? Yeah. Yeah, what are we gonna do today? And has anyone else weighed in on that we need to know about?
Medications.
Yeah, what are they giving? What did you give and why? Did you stop anything? Did you start anything?
Test results.
Test results, yeah. Abnormal and normal or just abnormal? What do you guys think?
I think it depends.
Okay.
I would say probably abnormal or maybe just what's changed. Like you could share a normal value if it had previously been abnormal.
Okay, so they have gotten better, their kidney function is now normal. Okay. Yeah.
What am I worried about?
Yeah.
It's unsettling me. What do I feel is missing? What's to me the things that I don't know are what I'm most afraid of.
Yeah, absolutely. Yeah. And what are they worried about too? Like the patient.
I guess like who was the last person, or do we need to communicate with the patient or the family regarding, I guess, updates?
Yeah.
When was the last time that happened?
Yes, and has anyone reached out, like has the family reached out with questions that they want answered?
Maybe a dumb question, but when I worked in urgent care, my physician would always ask like, what is their insurance?
Yeah.
Before they would sort of come with a care plan. Is that the case for hospitals?
It's really important when you're thinking about discharge planning. And you know, if you have someone that is uninsured and you're trying to minimize the impact of this stay on them, that's also important. When we're thinking about discharge planning, you know, are they gonna be able to get that expensive antibiotic as an outpatient, or should we try to get one more dose in before they leave? You know, are they gonna be able to go to a skilled nursing facility? Where do they live? What is their home like? Who is there to help them? My mom broke her hip in February. She has 16 steps, no matter how you count it, to get into her house. And no one there. And they were like, yeah, she can go home. She had done one stair in the hospital before they said she could go home, to a place that has like one rail on the side and that's it, and no support. But these are things we have to know about our patients, right? Like what is their life like too? Yeah, okay. So we talked about, I think you guys hit all of these, vitals and observations, notes and recommendations from our interdisciplinary team, lab results, interpretations, you guys said that, diagnosis, updated treatment plan, how is the patient doing, what are they worried about, their preferences, social context, action items, immediate follow-up. So we didn't touch on that as much, but you know, I talked to the renal fellow and they're gonna come do this today or whatever. And then the interdisciplinary team recommendations. So you guys hit on all those things. So with that, we'll start our brainstorm.
I always had a question about like why do people work 12-hour days? And I guess and a response I got was that for overlap, right? But overlap can occur with shorter work periods too.
Yeah.
So
Yeah, I think we do a lot of things because it's like the way we've always done them. There's some really interesting stories actually about the history of surgical rounds and why surgical rounds started so early. And there was a physician who had some substance use issues and some behavioral health concerns that led to him being awake very early, and he made then his whole team be awake very early, and it kind of created this culture of being awake very early and starting surgeries very early, no joke, that has like perpetuated to today. So there is a lot of just, you know, that also. I will say I trained when we did 30-hour calls and you really know what's going on. Like it is a lot easier to respond. It was physically awful, but it was a lot easier to respond to what was happening because you had been there the whole time and so you could very quickly sort of triage. Yeah.
I wonder, so when you think about continuity of care, we spend a lot of time with this in work we do scheduling in the emergency department because there's so much assessment going on and you've got so much kind of cognitive processing happening that's hard to hand off to somebody else. So if a patient's coming to the emergency department and I'm thinking it could be A, B, or C, and I'm gonna do a test for A because that's the most critical that I would have to, right? That act of handing off to someone, so the trade-off between what is the risk to both me and the patient of my being more fatigued versus what is the risk to the patient if I don't fully communicate everything in my head. And so I wonder if an environment like the ED where things are rapidly changing, the ICU where, you know, sort of how the patient has looked over the course of the day may be more important to have that continuity of care than say, you know, maybe a general ward where you've got people with pneumonias and things that are gonna be a little less jarred.
And so they used to call residents house officers, right? Because they like lived there and then it was residents because they were like residing there. And now it's trainees is more favorable, but some people don't like that either. But those terms came out of this concept that you would like move in for a while. Okay, so questions before we brainstorm and help me with how you guys wanna run the brainstorm portion.
I think we kind of already
we started.
just keep going.
I can jump off that.
Okay, I love it. So our goal is tactics to help the healthcare systems mitigate cognitive overload for providers. We can focus on rounding or not, whatever you guys want to do.
So, Dr. King was saying, but slightly different to bring back in, taking breaks is important, right? Even when you're locked in for a 30-hour call. I feel like decreasing cognitive load would be helped by the ability to take breaks, even if you have to like physically be there the whole time. And I know EHRs aren't like the best, but if there was a better system for having all of like the pertinent actionable information so you can clock out, take your 15 minutes or whatever, and come back and have all of the information that you can just jump right back into. Having something that's like actually nice and actually good and actually important to convey that information would not only help with people being able to take breaks, but could also help with continuity of care. Like doing rounds, like handing off to other people, just having a better system than the whole EHR all at the same time.
So what we didn't talk about that you're hitting on is the handoff, right? And this is how we do handoff when we're shifting. And so we have a written handoff and it has sort of a format that and people are better or less good at filling out the handoff, right? It's very variable. I have seen places where there is a section in the handoff to say overnight events and like the night person can fill in overnight events and then there's a dot phrase that you can put into your note in the day that says overnight events and that automatically pulls in. So if the overnight person didn't tell you what happened, it's at least in that handoff. And so I think like thinking about are there digital tools like the handoff that can make some of this easier? Yeah.
Instead of doing rounds, practice the one-liners that you actually will use once you're out of med school.
Yeah. So and it kind of gets to that guy's like 5 data point thing, right? Like give me something small and then let's go learn.
Yeah, and that would go faster and it would help spend more time with the patient and it would be something that instead of practicing synthesizing information into rounds, they would be practicing synthesizing information into like asking for help or asking for advice from other people.
And I love that because like could you do a one-liner and then say, and here are my 4 questions that I don't actually know the answer to. Okay, there are a lot and I don't know what order they came in. Yeah, go ahead.
I think the idea of selective attention itself can be a solution where I think a lot of issues are coming from organizational issues of, for example, the example you gave of 7 different, ways you're getting the same piece of information where they need to identify as an organization what are the pieces that need to be prioritized, and that's where you build the redundancy, that's where you build, you know, all those factors which require for that information to be out and present. But parts that do not need to be prioritized can be, I don't know, can be made a little bit easier, where it's not a safety risk, so it doesn't need to be, you know, something where you get 7 emails.
Yeah. And what I hear you saying is like, let's get together and be really intentional about what information actually needs to come.
Yes.
Yeah, like do our ED docs need all those alerts?
Yes,
Yeah.
organization of that environment and information.
Yeah.
So that the one that you want is essentially only signal, like you're prioritizing as much of the signal coming out and reducing noise.
Yeah.
About like based on the pre-readings and our conversation today, about the interruptions and kind of reducing the frequency of them or the time spent in that interruption, because like you mentioned that it takes like 90 seconds to get back into whatever you're doing. And I know we talked about how the ICU or like ER, there are a lot of interruptions, especially with those like multidisciplinary people, like care teams involved. So maybe if there's like 5 attending physicians, there could be a kind of like time period where each person is like open to being interrupted, and then the other 4 is like they're doing their work like they like, you know, like they're wearing their Red Sox cap, and then they can kind of take turns of who is the doctor that we go to in this time period.
So it's like addressing that available and tension, right? So that you can take that time off, that break, but someone's available. And what I like about that too is that teams can just do that. So I actually encourage my residents to do that, right? Just like you give your pager to this person and go spend an hour and have focused attention and write and think and then switch. And this is something that even within a team without organizational support you could do. I know we had
This will definitely be like over time, but just like maybe standardizing the rooms, because as you said, like in the different rooms they have things in different parts, and if that could just be like something automatic that you don't have to think about like where are these tools, and you could like use more of your working memory towards something else.
I love that. In fact, I'll just tell you, so John Sweller is the psychologist who's behind the theory of cognitive load theory, and I reached out to him when I wanted to start applying it to healthcare because it's an educational psychology principle and I wanted to make sure I wasn't misapplying it. So we were having a conversation and I was sort of explaining like I did to you, because he's not in healthcare, sort of explaining this is how we do it. And he said, wait a minute, are you telling me that units across different hospitals run their units differently? And I said, no. And he said, oh, thank goodness. And I said, I'm telling you, every unit in every hospital runs its units differently. And he's like, why would they do that? That's so dangerous. And I was like, I don't know. That's why we're having this conversation. Did you have an idea?
Yeah. My one question is like, I don't have a healthcare or any medical background. So do you know like the UI for the EHRs, like the online like health records? So that can automatically give you that one-liner, or these are the stats that have changed. These are like the lab tests, and this is what has decreased, this has increased. So instead of flipping through all of it.
Amazing. And with AI, we should have that technology. So my understanding is that our current EHR is working on having that capability, if not already has it, and we are in our sort of decision making about what we're turning on with AI. But I know that they are working on AI to sort of comb the chart also to look for missed things. So like data points that are missed, or like a pulmonary nodule on an x-ray that wasn't a big part of what we were doing in that stay but never got followed up on. So I think that's the future, like that is coming, and the question is when. Yes, absolutely, yeah.
Say you have everything in front of you on an iPad during rounding as opposed to like having to get information from different places. Is that actually all in one place, or knowing Epic, is it in like 18 different tabs with like 7 buttons you have to press to get to every tab?
So interestingly, but it also depends on the way you've deployed Epic. So I have now done this in 3 different institutions, and I will tell you that looks differently in the 3 different institutions, or it looks different in the 3 different institutions. depending on how it was designed and what was turned on. And that matters too, because then there's this like cognitive load of switching that. So some institutions have done it in a more consolidated way where your attention is less split, and others you are going between a bunch of tabs, which adds to split attention.
It seems like the EHR is the conduit for a lot of cognitive overload. And there is not a systematic approach to evaluating what gets put in there. If I could be czar, I would say that no one gets to upward delegate. No one gets to require a physician signature for a task unless they have a specific demonstrated reason and need for that. Right now, it's very easy for any administrator to just say, well, you have to have doc sign that. Similarly, no one gets to send you yet another discharge summary to your inbox unless they have a reason that they can't use the one that's already going.
Yeah,
And
and they
right
would
now-
know that I already got one. Yeah.
And right now, we don't have a system, any systematic approach to what we load into the EMR, as best I can tell. People are allowed to pile on cognitive load with no accountability for it.
Yes, and we've seen that right in the emergency department with the BPAs. We learned that that the team actually feels they struggle because they feel like they have these physicians, actually in this case, that'll come up to them and say, we need a BPA for this project that is my pet project that is so important that people know. And it's like, okay, but we have 35,000 BPAs firing a month and nobody is saying like, stop.
Nobody's saying the same thing to the pharmacy alerts either.
Yes. Yeah.
Yeah, so I think my questions, I guess it's two-parter. So the first one is, what is like the general approach to like screen usage? Like, do physicians like having many screens? Would they rather things be like really, like put on like a lot of TVs where they can see everything at once?
Oh, yeah.
Or are screens in a way overbearing? Cause obviously we know from our own personal use, like if you're on your screen or on your laptop, like the whole day, you'll get headaches, like just
Yeah.
blue light in general.
Yeah.
Are screens like generally
Yeah.
liked for that reason? Or, I mean, like what's kind of the.
I love the question because I've seen all variations, right? So there are still people that print the list and they have the list and they have like the multicolored click pens and they have their whole system of checkboxes and they love it and they like really like that. And this is, you know, even our current trainees. I've seen people that carry either laptops or tablets of some sort and are sort of checking through things. I have seen teams where they will pull up the screen in the patient's room at the bedside that the nurses often use to scan the meds, round that up so they can support the person who's rounding if there's any new labs or anything that's come up and they can say, you know, this happened, and show patients, here's your x-ray and here's whatever. And so there's this educational piece. What I love about what you're saying, which I've never thought about is like, what would it be like to have a large screen, you know, like have a large screen like this, but that the patient is involved in some way where you're actually sort of teaching in their structure to it. The other thing I've seen too is phones. So people will use a different version called Haiku and they will have already written their note but have it appended so it's not live so people can see, and then they'll read their note off their phone to present. And I've seen all of those.
And Liz, I think something we haven't talked about today, but that's important, is on the one hand, we've talked about standardization having value, but we're all different learners. And so the idea of, is it better to have it on one screen or on your phone or on a piece of paper? The answer is, it depends on who you are. And so I think part of what I want to add to sort of our list of, as we're evaluating solutions to whatever the problem is, being able to add to our thought process of, is this something that works for everybody? Is there a reason why we might need variations? And in particular layer on issues of disability and so on. Go ahead.
Yeah, so that's really interesting, cause I was thinking about it too, cause I know oftentimes, aside from screens, like whiteboards are used very frequently, like colored whiteboards, and so to your point, Mr. Cohn, like obviously there's much variability in how different physician teams operate, and maybe sometimes like trying to standardize it might cause more overload because it's like, I'm not used to like screens, or you could be someone who loves writing things out and you know, checking it off. My question, or I guess, my question would be, on aside from screens, thinking about like the physical layout of how we build hospitals from a physical blueprint like standpoint. I remember being in a conversation once with some administrators for the new pavilion. And one thing that I thought was really interesting is I believe in their post-op floors, they have centralized nursing stations, and they're very intentional in like where they put their nursing stations. So you could have a nurse in their one station that can see all of their patients all at once from their eyesight. And that was from a cognitive overload standpoint, like maybe that's beneficial, and being able to do your rounds in an area where it's very interconnected, where the whole system was designed for like making things as efficient from a physical, eye line or like walking, rounding perspective.
And what I love about that is like ideally there would be workstations for the whole interdisciplinary team there. And so then maybe you'd be sitting there as a team. And so if there's a question, you can have some of that sort of ambient interaction about it too. The other piece, just to add another learning style, is I used to have like an hour commute in Boston. I was an attending there for a while, and there's a feature where you can listen to the H&Ps through and so I would listen to all of the history and physicals from the night before of my patients as I drove in, right? And so just a different learning style, but that way that was my time to use my commute to be able to learn about the patients. Yeah.
I have more of like a general like staffing strategy kind of inquiry. So over the summer I did my internship here at Michigan Medicine in the ambulatory care team. And one of the projects I had was just kind of acknowledging and trying to formulate strategies around reducing or increasing access to primary care. And you said you're a PCP yourself. So yeah, I know there's like the thing is that there's not enough bodies. I don't think that's not enough bodies, it's just not enough PCPs. So how have you maybe seen so far in Michigan Med, like it being implemented to where we leverage the amount of APPs we have? So they can reduce the patient panels for PCPs and also take some of those like lower risk patients off their panel so they can commit more of their time to those higher risk patients. And yeah, I just wanted to see how you've seen the university kind of leverage the APPs that we have.
I think we can do more for sure. Like for example, there's one APP that works in my clinic. And she's brilliant and she's fantastic, and there is one of her. And so that like limits her ability, and she's very overworked. She sees a lot of our urgent patients. But to add on what you're saying, there's a program that was done in the perioperative or in the surgical triage space to say which surgeries are safe to have at the main campus and which are safe to have at sort of an outlying surgical center. And our PAs and APPs used to have to make that choice. And it was a lot of sort of tedious chart review that they found very burdensome and then contributed to their overload and wanting to leave. And they actually built an AI model that effectively does that with just now APP oversight, which has dramatically increased their sort of quality of life. The piece I'll add to that though is these systems things that we're talking about are so important to how many patients a PCP can see. So I actually have a smaller patient panel than I had before. But I personally, the way that we've set it up, I find it more challenging to manage all the in-basket messages and the patient panel that I have than I did before with different infrastructure. And so I think the question around what's going to the PCP and all that would actually, it's not just bodies, it's like the way we set it up and how many messages of all the messages that are sent from my panel, what percent come to me? And if it's 10%, I can have a bigger panel than if it's 65%. Right? And so I think that that question is really important too.
So in keeping with our cognitive limit at 80 minutes, we've gone a few over, but thank you to everybody who joined on Zoom and to everybody in the room for all of your thoughts. And thank you, Liz, for what is every conversation I walk away with like a new little idea and also a new little thought of, oh, I'm doing that wrong. So hopefully you all learned something useful today, and hopefully you learned some ideas, and we'll continue to go forward. But thank you very much. And we will see you all next week for Dr. Grace Jenk, who's going to be talking about, among many other things, issues specifically associated with caring for our older population and being more patient.
Geriatrics, let's go.
That was so cool.